Good evening, and I think a very good method of wrapping up, discussion and creating interest in therapy, because what is happening is so many things are available now, and we are still at play to understand what is what and what is correct. So I think someone well done with this format, and I think this is very important for people to understand what is good and what is not. My brief today is to talk about the role of MRAs in diabetic, especially with respect to similar. In fact, I would have liked if this should have spoken first, because I would be speaking against supplement as such. But nevertheless, I'll start my talk. So this case is basically about a 65-year-old diabetic female patient, old anterior MI, post PCI, 3 years back, chest imaging revealed mild reversible total of her, EF around 40, classic dyspnea, on data. Telmisartan exam, so obviously well controlled blood pressure, and apart from other DDMT for ischemic habits. Her UACR is 280, which is on the higher side. e-GFR is 48, which is low, but not that low to not do anything. Her current serum potassium level is 4.7. Again, not to rotation VPCs and ECG. The preferred MRA of choice would be. So, to my mind, I think Mineralocorticoid is a drug which would get best in this scenario. As you can see, I've done 4 or 5 boxes. So you have a diabetic female patient who has already undergone a PCI, ischemic heart disease with some residual ischemia. Ejection fraction 40, so there's a mildly DPF on DAPA, another DDMT, e-GFR borderline, UACR on the higher side. So the perfect setting, what I believe, is for this particular molecule. Why is this so? Because we know that PKD and diabetes both go hand in hand as far as cardiovascular disease is concerned. Diabetes alone is another cardiovascular risk factor. PKD alone is another cardiovascular risk factor. When put together, they are the worst of it. And why is that so? Because we know that there is a shared pathophysiological mechanism that link cardiovascular disease. The associated factors leading to the central nervous system activation, inflammation, endocrine dysfunction. We have the oxidative stress and dysfunction. So on and so forth will lead to various changes in thereby leading to both cardiovascular and kidney dysfunction benefits. So as you can see from this flow diagram, fibrosis is actually the primary driver of pathophysiology in several autoimmune syndromes, whether it can be heart failure, liver failure, whatever disease. Actually, fibrosis causes a problem. So focusing on fibrosis as a disease mediator could potentially be modulated with RAS inhibitors, MRAs, or other novel agents in development of prevention and treatment of fibrosis in the cardiovascular then contingent. If you can do that, nothing like it. We also know that albumin level increases is associated with higher cardiovascular levels across all e-GFR categories. Whatever the e-GFR be, whether it's normal, mild to moderate, or whether it is severely reduced, albuminuria itself causes high mortality risk. So albuminuria, CKD, when you have diabetes, these are all 3 major risk factors in this particular case, which sort of tells me that this case is tackled very well. Very fragile patient because again, increased basal UACR is strongly associated with increased risk of cardiovascular disease outcomes. We know that when the UACR is getting 30, and there is more than 1,000, this is a difference, it is nearly more than 1. And similar to case for renal outcomes, when the UACR is getting 30 and it is more than 1,000, it is nearly So we need to control all these factors. We need to control the progression of CKD, we need to control the progression of fibrosis, we need to control the overall pathophysiology of this patient. So what are the triggers that lead to the severe progression of diabetes? There are a mix of hemodynamic, metabolic, and inflammatory fibrosis, which leads to prevalent damage, inflammation, glomerular sclerosis, muscle expansion, glomerular hypertrophy, ultimately could be fibrosis and severe progression. So we need agents which work on all these areas so that the progression can be retarded. And what are they? Currently we have ACE inhibitors, ARV, diuretics, calcium channel blockers, ACE inhibitors which work at hemodynamic level, and they reduce the intraocular pressures, thereby reducing the hemodynamic damage to the kidney. We have ACE inhibitors, lipid analogs, metformin, and other agents which also metabolically regulate, improve the glycemic control, and also give better outcomes as far as the kidneys are concerned. We know ACE inhibitors particularly, they are renal friendly and they help in reducing the progression of CKD in diabetic patients. But what about the third part, inflammation fibrosis? We still don't have anything to work on that. We also know that despite RAS blockade and HSC inhibition, there is a lot of area still to be covered, a lot of results. Just as alone, combination, and otherwise, we can see that there is a definite resistance risk for CKD that keeps on going on despite whatever therapy we give. So there is a scope wherein we can put some molecules, especially which can act on the fibrosis and the other stuff. Therein comes in the role of MRA overactivation. So how does this work? It works as always mechanism. We have increased ligand-dependent MRA activation by aldosterone. Why is it important? Because it correlates with CKD and we have to study. And we have to alone itself is a marker for future cardiovascular events, arrhythmias, so on and so forth, and also for HFpEF, as you can see. Increased ligand-dependent MRA activation of cortisol. Again, it is very important because it's very heart failure mortality, and there is dysregulation which leads to further worsening of CKD. There is increased ligand-dependent MRA activation through RAC1 and oxidative stress, again which can lead to worsening of CKD, heart failure, and type 2 diabetes. And of course, there is MRA activation which increases in sugar into volume media. So we can somehow try and control the MRA overactivation. We will be able to control a lot of these various events and thereby reduce the overall progression. How does it cause kidney and cardiovascular damage? Okay, thank you. How does it cause kidney and cardiovascular damage? Again, the MRA pathway becomes overactivated with multiple mechanisms. Downstream effects being kidney damage, vascular damage, remodeling, the dysfunction, physical stiffness, mitral hypertrophy, ventricular remodeling, fibrosis, reduced coronary blood flow, system and function of the brain. So, as a cardiologist, for me, this is something very, very important. But I need to understand that MRA overactivation is not something that should or can be done, but it should be done. That is what I now feel after having gone through the whole gamut of heart failure and CKD. It is also a potential treatment target to address the resistance in CKD and type 2 diabetes. This is where we need to work because everything else is still there, right? So it is fentanyl which targets the MRA overactivation, which may contribute to kidney and cardiovascular disease progression, patients CKD and type 2 diabetes, and thereby it blocks the MRA overactivation and therefore it reduces the albuminuria, it reduces the CKD progression. It also helps as far as the blood pressure is concerned. It has a more or less neutral effect as compared to spironolactone or trinate. It's a more or less neutral effect. So heart failure patients like elderly females who are just about there hemodynamically, it could be a good drug to act. And we have a lot of animal studies which show that fibrosis in heart and kidneys are definitely prevented when the patients are given sindramine as compared to epinephrine or even spironolactone. What is also important to understand is that it is pretty safe. The ARC study, the ARC study very clearly showed that as compared to spironolactone, as compared to epinephrine, the hyperkalemia that was seen was far less as compared to the other molecules. And if you look at the NT-proBNP levels with this particular molecule, again, there was a significant reduction in NT-proBNP levels when this particular molecule was given as compared to both epinephrine as well as spironolactone. So for me, this is a molecule which should work in this particular subgroup because elderly female, post PCI, EF 40%, CKD with UACR is on the higher side. Definitely, I would not hesitate in adding this particular molecule. Again, you look at the emphasis HF, the result very clearly showed that patients treated with epinephrine had an increased risk of potassium, but not of potassium more than 6, and of hospitalized hyperkalemia or discontinued studied medication to reduce event. So this is one area which I feel that again works better. Currently, it is indicated in adult patients CKD associated with type 2 diabetes to reduce the risk of sustained e-GFR decline and kidney disease, cardiovascular death, non-fatal MI, and hospital heart failure. Also, what is important to understand is that it also reduces the incidence of new onset atrial fibrillation. So it is cardio safe, renal safe, reduces albuminuria, prevents AF, reduces heart failure hospitalization, especially in patients with HFpEF, bind-reduced EF, where it has been studied in fidelity, and the Figaro-DKD trial, it has been shown to be beneficial. And therefore, I'll just jump the slide because these are all numbers which I think we will always find everywhere. But the cardiovascular benefit of finerenone was not modified by prevalent ASCVD status, like in this particular patient. Known ASCVD, only undergone PCI, this patient would benefit more with the finerenone as compared to a placebo or another molecule alone. It also reduces the risk of composite kidney outcome as compared to placebo, irrespective of ASCVD history, and therefore I think for me, finerenone would definitely be the molecule of choice. So, if you look at the guidelines currently, AHA 2022 recommended, ACE 22 clinical trial pattern. I'll just check 2 more slides. Level 1A, ADA KDIGO guidelines recommended definitely by KDIGO guidelines 2022 level 2A, ADA 2023 guidelines level A recommendation for this molecule. And we talk about the pillars for reduction in diabetes complications. We have glycemic management, blood pressure management, lipid management, and agents of cardiovascular renal benefit, and which are RAS blockade, SGLT2. We know that these two are already there, still there's a residual risk, and to control that, now we have Fundinone, which can definitely help, especially in this particular group of patients. So 65-year-old diabetic, EF 40, GFR of 48, UACR of 280, potassium of 4.7. I would not hesitate in adding Fundinone and giving the best possible benefit. So I think given the wealth of data now that we have with Fundinone, cardio-safe, renal safe, albuminuria reduction, improvement in heart failure, reduction in heart failure hospitalization, I think this is one molecule will definitely add as compared to other molecules. Only 5 key takeaways. 1, initial treatment and serum potassium less than 5. Withhold treatment serum potassium more than 5.5. Initial treatment e-GFR is more than 25. This is something we need to understand. Fundinone reduces the risk of ESCVD by 1/5 and reduce the risk of hospital heart failure by 1/5. This is a very important slide. Please remember it and take it home. Thank you very much.
Sir probably may not remember me, but sir has taken my DNB final exam few months back only. And I am very thankful to Dr. Kamal Sharma, Cardiocon team to provide me this support. Sir maybe arbitrarily hide the fact that patient has class 2 dyspnea on exertion, except that patient is 65 female, ischemic heart disease, diabetes, CKD, or we call it diabetic kidney disease, with LVEF of 40%, and with so effectively patient is of case of the heart failure with reduced ejection fraction according to newer all heart failure guidelines. So our patient managed based on the heart failure with reduced ejection fraction guideline, and there are 4 pillars everyone knows of. So elaborately, MRA is one of the pillars of the heart failure with reduced ejection fraction, and eplerenone is more specific for aldosterone blockade and therefore causes less gynecomastia, causes less vaginal bleeding, and it is already better than the spironolactone. And this is the AHA 2022 guideline heart failure. It is also suggested MRA, spironolactone, and eplerenone is recommended with careful with the e-GFR more than 30 and potassium is less than 5. And one value statement, high value statement, MRA therapy provides high economic value. And these are the trials supporting the MRAs long way back, FSS in the acute MI setting and emphasis with the chronic heart failure setting, which shows that it reduces the heart failure hospitalization as well as cardiovascular death. This is the only study or only I can found in the literature. This is versus the Fundinone versus eplerenone, and this is particular study is important. This is the dose finding study for the Fundinone, but it was thus show that the Fundinone is well tolerated. It reduces the anti-proBNP level, and it has the similar to cause the hyperkalemia, not better than. And this is the inclusion criteria for the Figaro DKD and Fidelio DKD, which are 2 largest trial available with the Fundinone. And these are the one exclusion criteria. They have excluded the patients with clinical diagnosis of chronic heart failure with reduced ejection fraction and persistent symptoms with NYHA class 2 to 4. So their patient in the trial, large number of patients are mainly NYHA1, or we can say that the asymptomatic patients with long-term diabetic and chronic kidney diseases. So they have excluded. So class 1 indications. So we can say that there is no head-to-head comparison with eplerenone versus Fundinone. And this is detailed analysis of the sir has already talked about this fidelity analysis, and this has a similar experience of the hyperkalemia with both the drugs. This is with the eplerenone emphasis trial. There is 1.5 times more the hyperkalemia, and with hyperkalemia with the finerenone from fidelity analysis is almost twice. There may be permanent discontinuation was drugs was also twice than the placebo. So from my point of view, mRNA eplerenone is still class 1A indication in symptomatic heart failure patient with reduced ejection fraction, and place for finerenone will be decided after fine arts heart failure reduced trial. Till now we have to wait to include in the heart failure guideline. And hyperkalemia is issue is common with all mRNAs. Caution must be taken with low e-GFR, and current post of the finerenone is also issue. So from my side, symptomatic patients with diabetes and diabetic kidney disease, older generation mineralocorticoid receptor antagonist eplerenone is better, and for asymptomatic patient for prevention purpose we may consider finerenone after SGLT2, GLP-1 agonist and AC inhibitor. Thank you.